Welcome to the deep dive. We're here to, well, dive deep into complex topics and pull out the key info you really need.
Making it stick.
Exactly. Today, it's hydatid cysts. We've got revision notes here, and the aim is to get a solid grasp on this condition for, effective recall.
Yeah, medical stuff can seem overwhelming sometimes.
Totally. But we'll break it down, make it clear, maybe even a bit engaging. We'll cover the definition, the causes, risks, how it develops.
Pathophysiology, yeah.
And what else? And could be the differentials.
Right. Plus, where it occurs, how it looks clinically, investigations, treatment.
Prognosis, complications, the whole picture, basically, but streamlined.
Okay, let's jump right in. Definition first. What exactly is a hydatid cyst?
Okay, so in simple terms, it's a parasitic cyst. It's formed by the larval stage of this tapeworm, Echinococcus granulosus.
Yeah, tapeworm larva, got it.
Yeah. Think of a sac filled with fluid, but it has this thick, fibrous outer wall. They can show up in different organs.
Which ones mainly? Well, they really like the liver and the lungs. Those are the top two. But you can also find them in the spleen, kidneys, even the brain sometimes.
So definitely not just a simple fluid collection then.
No, definitely not. They grow, and as they grow, they can damage the organ they're in, cause problems, complications. It's a real issue.
And you mentioned location. Is it more common certain places?
It is, yeah. Much more common in places like the Mediterranean region, the Middle East. So travel history or where someone's from, that can be a big clue.
Okay. And the root cause, how does someone get this in the first place?
It all starts with swallowing the eggs of that tapeworm, Echinococcus granulosus, usually from contaminated food or water, often linked back to infected dogs.
Right, dogs are involved somehow.
They are. And treatment, well, it can be complex, often needs a mix of things. So really understanding the condition is pretty vital.
Sounds significant on a larger scale, too.
Oh, absolutely. The WHO, the World Health Organization, they actually had a target for controlling this disease by 2020. That tells you something about its global health importance.
Right. Okay, so that's what they are. How do they actually form the etiology?
So as we said, it starts with swallowing those tiny tapeworm eggs, contaminated food, water. You ingest them.
Accidentally, of course.
Yes, accidentally. Once they're in your small intestine, these eggs hatch. Out come the larvae.
And then they don't just stay there.
No, they're mobile. They manage to penetrate the intestinal wall, get into the bloodstream, and then they travel. They migrate to different organs.
And the body just lets this happen.
Well, the body reacts.
Yeah.
The immune system recognizes this invader and tries to contain it. It forms that protective cyst wall around the larva, that thick fibrous layer we mentioned. It's trying to isolate it.
A containment strategy. Okay, so who is most likely to swallow these eggs? What are the big risk factors?
Okay, several key things. First, geography. Living in or even just visiting those areas where it's common, Mediterranean, Middle East, again.
Got it. Travel history.
Yep. And then really importantly, close contact with dogs or potentially other animals that host the adult tapeworm. Sheep are common intermediate hosts in the cycle.
So dogs are key in the transmission.
Very often, yes. And poor hygiene practices really increase the risk, both around animals like not washing hands after contact and just general personal hygiene.
Any specific examples with dogs?
Sure. Things like feeding dogs raw offal that's organ meat, like liver or lungs from sheep, potentially which might contain the cysts. Also letting dogs roam free where they might eat infected carcasses or pick up eggs.
So regular close contact with dogs in those endemic areas.
Combined with perhaps less than ideal hygiene, yeah, that's a significant risk profile.
Okay, that makes sense. We've got the what and the how you get it. Let's dig into the how it develops inside the pathophysiology.
Right, so egg ingestion, larvae hatch in the gut.
Burrow through the wall.
Exactly. Into the bloodstream, and then they usually lodge themselves in the liver or the lungs. Those are the prime locations. And there, they start to form these cysts and grow.
Like setting up shop.
Pretty much. Fluid-filled sacs. And as they get bigger, they obviously start putting pressure on the surrounding tissue.
And the body's response, that fibrous wall.
Yeah, the immune system creates that fibrous capsule to try and wall it off.
Yeah.
But here's a key point. If that cyst ruptures...
Ah, that sounds bad.
It can be. Rupturing releases the parasitic material, the fluid, maybe even tiny larval heads into the body. This can cause a severe allergic reaction, or it can lead to the parasite spreading and forming new cysts elsewhere, secondary cysts.
Wow, okay, so rupture is a major event.
Absolutely. And this whole thing operates in a cycle, right? A two-host cycle. You've got the definitive host, often dogs, harboring the adult tapeworm in their gut.
Yeah.
They pass the eggs in their poo.
Right.
Then an intermediate host, like a sheep, eats grass contaminated with these eggs. The larvae hatch inside the sheep and form cysts in its organs.
Okay.
The dog then gets infected by eating the infected organs of the sheep. Cycle complete.
And humans, where do we fit in?
Humans usually get infected like the sheep by accidentally swallowing the eggs. Often from contact with infected dogs or contaminated environments. We're typically considered dead-end hosts, meaning the parasite life cycle doesn't usually complete in us. The larvae form cysts, but they don't mature into adult tapeworms.
And this can all be happening silently.
For a long time, yes. These cysts often grow very, very slowly, years, sometimes decades, without causing any noticeable symptoms.
So the clinical presentation must vary a lot then.
Hugely. It really depends on the cyst size, which organ is involved, and whether there are any complications, like rupture or infection.
Okay. So if someone does have symptoms suggesting a cyst, what else might be going on? What are the main differential diagnoses?
Good question. Very important clinically. If we're talking about the liver, which is common, you need to consider other things that cause cyst-like lesions. Simple liver, cysts the non-parasitic kind.
Okay.
Liver abscesses, that's a collection of pus. And of course, liver tumors, both benign ones and, importantly, cancerous ones.
So quite a range just for the liver.
Definitely. And if the cyst is suspected elsewhere, say the kidney, you might think about pyonephrosis, that's like an abscess within the kidney's collecting system, or more generally, things like epidermoid cysts, other types of simple cysts. And you always have to keep neoplasia, abnormal growths, tumors in the back of your mind, just to be safe.
Rule out the serious stuff.
Exactly. It's about using the clinical picture and the investigations to figure out which is most likely.
Right. Let's talk geography then. Epidemiology. Where do we find these things?
Echinococcus granulosus is pretty much worldwide, found across Asia, North Africa, the Americas, Europe, Australasia. It tends to be more common in areas with significant sheep farming, where that dog-sheep cycle can perpetuate easily.
What about here in the UK? Any hotspots?
Yes, there are areas in the UK where it's known to be more endemic. Parts of Wales, Herefordshire, and the Western Isles of Scotland are often cited. It's also worth knowing about a different species, E. multilocularis, which causes a more invasive form called alveolar echinococcosis. That's found mainly in the Northern Hemisphere, parts of Europe, Asia, and North America. There's always a slight concern about potential spread, so surveillance happens.
But overall prevalence in the UK?
Generally considered low currently, thanks to things like meat inspection, deworming programs for dogs, changes in farming. So while it exists, it's not as common as in some other parts of the world. Travel history remains important, though.
Good to have that context. Okay, clinical features. How does someone with a hydatid cyst actually present? You said it's variable.
Highly variable. Really depends on location, size, complications. But some common things might be abdominal pain or just a feeling of discomfort or fullness.
Yeah.
Maybe an enlarged abdomen if there's a big liver cyst.
Okay.
Jaundice, yellowing of the skin, and eyes that can happen if a liver cyst presses on a bile duct.
And if it's in the lungs?
Then you might see things like a persistent cough, chest pain, or shortness of breath, especially if the cyst is large enough to compromise lung function. Remember, liver and lungs account for like 90% of cases.
Do they usually cause symptoms early on?
Often not. Cysts can be totally asymptomatic for ages. Symptoms often only start when they get pretty big, maybe over 5 centimeters or so, or if a complication happens.
That's bursting.
Exactly. Morbidity illness often comes from bursting, getting infected, or just the pressure effect causing organ dysfunction. If a liver cyst bursts into the bile ducts, there's a classic triad to look out for: severe biliary colic, pain, jaundice, and urticaria hives.
That triad sounds like a key thing to remember. Biliary colic, jaundice, urticaria.
It's a strong pointer towards biliary rupture, yeah.
Oh.
And just to be clear, in the UK, the usual culprit is E. granulosus, causing what we call cystic echinococcosis. Symptoms depend on size, site, complications.
And the slow growth means symptoms develop slowly too.
Generally, yes. Pressure symptoms build up gradually. The exception might be in very confined spaces, like the brain or maybe the eye, where even a smaller cyst can cause problems sooner because there's just no room.
Can you give a couple more organ-specific examples?
Sure. For the liver, besides the jaundice and pain, sometimes, if it ruptures into the bile duct, patients might actually vomit up bits of the cyst lining the hydated membranes.
Wow, really?
Yeah, quite specific when it happens. For the lungs, besides the cough and breathlessness, you might get hemoctasis, coughing up blood. And always think about complications as part of the presentation. Infection, anaphylaxis if it ruptures, cholangitis, bile duct infection.
And briefly, those other types, alveolar and polycystic.
Right, less common. Alveolar, from E. multilocularis, often present more like a tumor liver disease, cholestatic jaundice, epigastric pain, and it has this nasty habit of infiltrating, almost like a cancer, and can metastasize, spread to distant sites.
Okay.
Polycystic, from E. vogelii, or E. oligarthris, found in Latin America, is rare. Tends to involve multiple organs with multiple cysts, often the liver again.
Okay, quite a spectrum. So, given all that variability, how do we actually investigate and confirm the diagnosis?
Imaging is absolutely central. Ultrasound is often the first step. It's widely available, non-invasive, good for looking at the liver, for instance. You can obviously see the characteristic features of the cyst.
Like the wall and the fluid.
Exactly. Maybe even daughter cysts inside. But CT scans are generally considered the best for really defining the cyst, seeing its full extent, its relationship to blood vessels or bile ducts, and distinguishing it from other things like abscesses or tumors.
And MRI?
MRI can be very useful too, gives excellent soft tissue detail. Might be used for complex cases or looking at specific locations like the brain.
So imaging lets you actually see the cyst?
Correct. Visualize it, measure it, see what it's doing to its neighbors. Then, alongside imaging, we use serology blood tests.
Looking for antibodies.
Precisely. Tests like ELISA or IHICA look for antibodies the body makes against the Echinococcus parasite. A positive test strongly supports the diagnosis.
Are they always positive?
Not always. Sensitivity varies a bit depending on the cyst location and status, but they are a really important piece of the puzzle. They can also be used to monitor treatment response sometimes.
Any role for taking fluid out of the cyst? Aspiration?
It can be done, but cautiously. It's usually reserved for specific situations, maybe when the diagnosis is really unclear or as part of a treatment procedure like PAIR. There's that risk of leakage and anaphylaxis or spread of the parasite if not done carefully. But examining the fluid can sometimes confirm the diagnosis by finding parasitic elements.
So summing up investigations. Ultrasound first, maybe, CT for detail, serology for confirmation, and follow-up.
That's a pretty good summary. Radiology is key for detection and differentiating from other lesions, potentially using guided punctures or biopsies in select cases alongside those antibody antigen tests.
All right. Diagnosis made. What's the management strategy? How do we treat hydatid cysts?
Management depends on the type of cyst, the size, location, symptoms, and the patient's overall health. But generally, the main options are surgery, medication, or sometimes specific interventional procedures, and then watchful waiting in some cases.
Surgery sounds like a major option.
It often is, especially for larger, complicated, or symptomatic cysts. The goal is complete removal of the cyst without rupturing it. Needs an experienced surgeon. Sometimes minimally invasive approaches like laparoscopy are possible.
And medications, you mentioned albendazole.
Yes, antiparasitic drugs like albendazole, that's the main one, or mebendazole if albendazole isn't tolerated. These can be used before surgery to try and sterilize the cyst contents or reduce tension, making rupture less likely, or after surgery to reduce recurrence risk, or even as the primary treatment if surgery isn't feasible for some reason.
How do they work?
They essentially kill the parasite larvae within the cyst. This can shrink the cyst, or at least stop it growing, and reduces the risk of spread if there's any accidental spillage during surgery or if the cyst were to rupture spontaneously.
So it's often a combination.
Very often, yes. Surgery plus medication offers the best chance of cure usually. But even with successful removal, long-term follow-up with imaging and maybe serology is crucial because these things can sometimes recur or new ones can develop.
You mentioned PAIR earlier.
Right. PAIR stands for puncture, aspiration, injection, reaspiration. It's a minimally invasive technique used for certain types of uncomplicated cysts. You puncture the cyst under ultrasound guidance, aspirate the fluid, inject a scalicidal agent, something to kill the larvae, like hypertonic saline or alcohol, leave it for a bit, then reaspirate. It avoids open surgery.
And the watch and wait approach.
That might be considered for very small, stable, asymptomatic cysts, particularly calcified ones that are likely inactive, but it requires careful monitoring.
What about the alveolar type, E. multilocularis?
That's managed differently because it's infiltrative. The ideal is radical surgical resection, like removing a tumor, plus long-term chemotherapy with albendazole. If it's inoperable or only partially removed, then long-term, potentially lifelong, chemotherapy is the mainstay. Liver transplantation can even be an option in severe cases.
Okay, so quite involved management. What's the general outlook then? The prognosis?
It really varies. Depends on the cyst type. Cystic is generally better than alveolar. Also depends on size, location, number of cysts, any complications, and crucially, the effectiveness of the treatment received.
But with treatment?
For cystic echinococcus, E. granulosus, if you get timely diagnosis and appropriate treatment, like surgery plus medication, the prognosis is generally favorable. Recurrence rates are relatively low with good technique and drug coverage.
But complications can affect that.
Definitely. If you have a rupture, a major anaphylactic reaction, secondary infection, or widespread dissemination, the outcome can be much more severe. So early diagnosis and intervention are key.
And prevention. Can we stop people getting it?
Prevention is tough on the individual level, as there aren't human vaccines or preventative drugs right now. The focus is really on interrupting the transmission cycle in animals.
Ah.
Key things are regular deworming of dogs, especially in endemic areas, preventing dogs from accessing potentially infected carcasses or raw offal from livestock like sheep, improving slaughterhouse hygiene and disposal of offal, public education about the risks and hygiene measures, like hand washing. Absolutely. Hand washing after contact with dogs, soil, thoroughly washing fruits and vegetables that might be contaminated. There's also work on a vaccine for sheep, the EG95 vaccine, which looks promising for breaking the cycle in livestock.
Interesting. Okay, lastly, let's just recap the potential complications. What can go wrong?
The big ones we've touched on. Cyst rupture is probably the most feared immediate complication. It can cause that severe allergic reaction, anaphylaxis, due to the release of cyst antigens.
Potentially life-threatening.
Yes. Rupture can also lead to the spread of the parasite, seeding new cysts elsewhere in the peritoneal cavity, or pleural space, for example. Secondary bacterial infection within the cyst is another issue, essentially turning it into an abscess.
Nasty.
And then there's the effect of large or multiple cysts just compressing adjacent organs or structures, blocking bile ducts, causing jaundice, compressing blood vessels, or impairing organ function like the lungs or kidneys.
So a lot can potentially happen if it's not managed properly or if things go wrong.
Exactly. It underlines why awareness, early diagnosis, and careful management by experienced teams are so important.
Absolutely. Well, that was a really comprehensive run-through of hydatid cysts, from the tapeworm life cycle right through to management and complications.
It's definitely a condition to keep in mind, especially with the right exposure history or geographical background.
Definitely. Key takeaways. Remember the dog-sheep cycle, the importance of hygiene, the varied presentation, the reliance on imaging and serology, and the combined surgical medical approach to treatment often needed.
And the potential for serious complications if rupture or infection occurs.
Which brings us to a final thought. Given that these cysts are found globally and can be asymptomatic for so long, what role could greater public and healthcare professional awareness, maybe even targeted surveillance in some areas, play in catching these earlier and improving control? Something to ponder.
A very relevant question.
For more high-yield revision resources, do check out PASMSRA.com and also FreeMSRA.com.
Great resources there.
Thanks for joining us for this deep dive into hydatid cysts.